I want to talk about guide-induced dissection management, and I will show some cases to illustrate that. This is a 64-year-old female who presents with non-STEMI. She has a calcified mid-RCA stenosis, and she has a true distal RCA bifurcation disease involving the PDA, large PDA, and large PLB branch. So the plan was to do mid-RCA stenting as well as a two-stent strategy distally using the nano-crush perfect T technique. We decided to use a 7 French AL1 guide. AL1 is my preferred transradial guide and it's supportive. Try to avoid use a GR4 guide transradially. It provides very little support. And the reason I went with 7 French is one, for the extra support we get with it. Two, when we do a nano crush, that involves placing a simultaneous stent balloon at some point, which can be done with 6 French when the stent and the balloon are less than 3.5 millimeters, but it's easier with 7 French. Now you already see on this image there is a problem. This guide is too deep and it's not coaxial. It's eccentric and abutting the wall. So it's already a risky guide and a risky injection. And indeed, you see on that next shot here that we have a guide-induced dissection at the guide tip. And that dissection is due to both the mechanical effect of the tip as well as the hydraulic effect of the contrast injection. And note that this dissection occurred even though the guide pressure was not damped or ventricularized. And those are the general reasons for guide dissection. One is injection while the guide pressure is damped or ventricularized, which means that the guide is occlusive or the guide is against the wall. Number two, you have an aggressive deep guide as we had here with non-coaxial eccentric tip abutting the wall, even if you're not ventricularized, especially during contrast injection or especially during your case when your guide is frequently pushed in and out and off and on abutting and hammering that wall eccentrically during difficult balloon or stent advancement and retrieval. Third common reason is deep guideliner. Another reason in this case is the way the guide was engaged. You see the guide was deep, but the reason it was deep is that it was engaged inappropriately. Here is how it should be engaged. I had to re-engage the guide in this patient, and this is how I did it. I have a talk about Amplatz left guide manipulations that I suggest you review. And the way we engage in Amplatz left is, one, you have to have it in an elongated fashion. You have to have the tip elongated and free on the cusp of interest. That's always the starting point. Those are 3 key words: elongated and free on the cusp of interest, right cusp in this case. So while the Amplatz left tip is elongated and free on the right cusp, you torque, and midway through your torque, you push to give it that duck shape and engage. So elongated and free, then you torque, and midway through your torque, you push to engage and have it duck shape. And if you become duck shape early on and your catheter point up early on before you're pointing to the RCA, it's best to pull and keep it elongated early on. It's best not to be fully duck shaped and looking up until you're close to engaged. The issue here is that the initial fellow's engagement was more abrupt. While he was torquing, he was stuck in this position. Then all the torque got abruptly transmitted and the catheter went deeply in the coronary all of a sudden. And that was the first problem. Then the second problem was keeping it deep and eccentric and injecting in that position. Now, once you have a guide-induced coronary dissection, whether of the left main or the RCA, what do you do next? There are two different scenarios. If you already have a wire across, then stent proximally to tuck the origin of the dissection, the entry site, and to collapse that hematoma, then deal with the distal disease afterward. If you don't have a wire across, that's a bigger problem. You need to do one thing, a next step before wiring, then you wire, then you stent proximally to tuck the origin of the dissection, then deal with the distal disease afterward. And I will discuss what is that next step before wiring. So first, let's go to the scenario that you have a wire across. So if you have a wire across, stent proximally to tuck the origin of the dissection, the entry site, and collapse the hematoma, then deal with the distal disease afterwards. So you stent here the origin. The red is that dissection propagating distally. You tuck the origin of the dissection. This often reestablishes flow, and the whole hematoma will likely improve and at least partially collapse. If the dissection is not too extensive distally, it is nice to also cover the distal edge to prevent propagation of the hematoma. But pure distal stenting is less effective than stenting the entry point and is less likely to reestablish flow by itself. Also, the downside of starting with distal edge stenting is that you may not be able to see where the distal edge is in long spiral dissection or in occlusive dissections. Use a relatively longer stent to ensure covering as much of the dissection as possible. Use a properly sized or slightly undersized stent to avoid propagating the dissection. If you see where the dissection ends, try to cover the distal and the proximal edges of the dissection. And in any case, after proximal stenting, inject dye and assess the distal vessel. If there is residual dissection distally that is not too long, tuck it with another stent overlapping with the proximal one. If there is no flow, poor flow, you don't know where that dissection ends, or the dissection has spiraled extensively distally, just focus on covering the entry site of the dissection. The proximal part of the dissection, this will likely collapse the extensive distal propagating hematoma and re-establish flow. Occasionally, if TIMI flow is less than 3, despite proximal stenting of this long spiral extensive distal dissection, it may mean that the distal portion of the hematoma is still occlusive. So what you do is distal undersized ballooning to reestablish flow, plus or minus cutting balloon to tear and decompress that hematoma. Also keep in mind, if you had to rewire, then consider the possibility that your wire is in the false lumen and what you stented is in fact the false lumen, and that's why you're not reestablishing flow. So it's very important to IVUS in this case and make sure you're in the true lumen. If dissection extends in branches, again, just covering the entry site of the dissection and the main vessel will likely collapse that hematoma and its propagation into side branches. So it will reestablish flow into branches, just tucking the entry site of the dissection. Another idea that applies to all significant dissection, whether guide-induced or stent or balloon-induced, stop injecting contrast or limit it as much as possible, such as less than 1 to 2 milliliter per injection and gentle, not forceful. You will need some injection when you're positioning the stent, but keep it small and gentle. No need to inject any contrast while wiring. Just use your tactile feedback and your knowledge of the anatomy while wiring. No contrast during wiring. Now, if you have a guide dissection and you do not have a wire across the coronary, as was the case here, so what do you do next? So it's more tricky in this case because you don't have a wire, so you need to know how to wire through a guide-induced dissection, and you need to do something before you wire. And that something is typically changing the guide to a guide pointing in a different direction away from the dissection plane. So in our case here, if I use that same guide and try to wire through, that guide is pointing me toward the dissection that it has induced. So if I try to wire, I'm going to most likely go into that dissection plane and extend the dissection. So the best next step is to change that guide to a guide pointing in a different direction, then wire it. Now, occasionally you may try to wire via the same guide, particularly when it was difficult to engage and multiple guide exchanges were already made and were necessary. For example, when you have difficult takeoff or difficult transradial aortic anatomy. But if you try with the same guide, at least try to be more disengaged. So pull it out, change the look of the guide if possible. And in any case, you may want to briefly try with your current guide, but any wire buckling implies subintimal wiring, and be swift to change guide in that case. Now, once you engage with a different guide, how do you wire? That's the other difficult step. And here in this case, I tried to re-engage with the M+ guide using a proper technique, not the abrupt technique that was initially done. And I tried to wire briskly, but it didn't work. So I switched to a JR4 guide and a BMW wire. And the key as you wire is to avoid buckling and knuckling the wire at any time. Wire buckling means subintimal plane. So watch here how I wired very quickly. So GR4 guide and BMW, look, any buckling, I pull back and I rewire. I spin the wire quickly and I let it slip without any buckling or any knuckling at any time. So if you see buckling, you pull back and you keep spinning the wire like a helicopter as you are advancing it. This is how you ensure you are in the true lumen. And those are the ideas. Wire buckling means subintimal plane. So you pull back and you keep flipping the wire like a helicopter as you are advancing it. If you buckle, you pull back again and you keep flipping the wire, avoiding any buckling. And this is how you ensure true lumen. Those are 6 tips that will help you. Avoid buckling and avoid knuckle, which could mean subintima and subintima propagation. Twirl the tip, helicopter that tip. Going in and out of side branches usually suggests true lumen, so it's reassuring. No PVCs, avoid PVCs. If you see too many PVCs, that means you're in the deep subintima. Again, pull back and rewire. May consider microcatheter distal injection after you've made some ways distally. You consider microcatheter distal injection via dual lumen catheter, but this is risky as it may extend the subintima if you are in a dissection plane. But you may do it, especially if you're believing you are in the true lumen. You may also consider IVUS if you have the time and the patient is not crashing hemodynamically. And if you do IVUS, you need to know how the true lumen looks and how the subintima looks. The subintimal hematoma looks like a circumferential or banana-shaped dark structure. This is how the subintima false lumen looks. Crescent, banana-shaped dark structure, sometimes with white speckles, whereas the intima is white. This is another false lumen. Here it's more circumferential false lumen, whereas the intima here is white. This is another image from a SCAD subintimal hematoma, but it's the same morphology. It's a crescent banana shape, dark structure with white speckles, and it gets darker as you go deeper. And this is the intima, white. Again here, this is that subintima, dark crescent structure, whereas the intima is white. Now, what happens if using those maneuvers you cannot get into the true lumen and wire the true lumen? In that case, you keep the wire that is in the false lumen, you keep it, plugging that false lumen, and you try to advance another wire while the first wire is plugging the false lumen. The way you know that first wire is the false lumen is that it's buckling and knuckling and it has resistance, and you're not able to redirect it and spin it easily. So in that case, after multiple attempts and you're kind of stuck, you're not able to progress distally, you keep it in that place, you try to advance another wire. Now, if that other wire has difficulty being advanced, it's possibly that it's going to that subintimal hematoma, which is potentially quite big, especially if you've injected a lot of contrast already. So in that case, what you need to do the straw technique. So you advance a microcatheter over that wire that is in the subintima, particularly a dual lumen like a Sasuke microcatheter, and you aspirate via that dual lumen catheter to collapse the subintima. This is what we call the straw technique. We decompress the false lumen, and this will allow that red second wire to succeed in going into the true lumen. So again, if you cannot get in the true lumen and vessel is fully compressed by hematoma, you may try a polymer wire instead of a BMW wire to slip in the true lumen using the prior maneuvers. You may also need to parallel wire, meaning you keep a subintimal wire in place, plugging the subintima, and you advance another wire. You may need to advance a microcatheter over the subintimal wire, especially a dual lumen microcatheter, and aspirate through it to decompress the false lumen and allow the second wire to succeed. Another thing you can do in those cases where you fail to rewire is to use 2B3A antagonists. It may seem counterintuitive to use them, but they do actually help reestablish flow, and they are recommended in flow-limiting iatrogenic dissection, not SCAD, in iatrogenic dissection. Why they are good? Because they help prevent true lumen thrombosis and they maintain flow in occlusive dissection. What happens when you have bad occlusive dissection is that the hematoma compresses the true lumen and that true lumen may thrombose. So the 2B3A antagonists may prevent the true lumen thrombosis. Another thing the 2B3A antagonists do is that they may also help decompress that subintimal hematoma. They help it burst back, rupture into the true lumen. Avoid them if the dissection extends into the aorta, aorto-coronary dissection, or if there is any question mark about perforation. This is from the landmark replace 2 trial of 2B3A antagonists, and in the control arm, they allow the use of 2B3A if you have obstructive dissection. This is from the ESPRIT randomized trial of 2B3A antagonists. Again, they allowed the use of 2B3A antagonists in the control arm for abrupt closure, such as abrupt closure from coronary dissection. Now to go back to our case with a GR4 7 French guide and the BMW blind rewiring, we ballooned with an undersized balloon, then we stented from the ostium all the way to the mid-RCA. We actually covered the mid-RCA stenosis. We used a 3.5 by 38 millimeter synergy drug-eluting stent. It was a slightly undersized stent on purpose to avoid propagating the hematoma. So we may undersize the stent in those cases and try to avoid aggressive post-dilatation to avoid also propagating that hematoma. And this is the result after proximal stenting. You still see the dissection behind the stent, but it's stuck behind the stent. So there is no concern of this dissection propagating. So this is a summary of some additional tips. Stent slightly undersized to avoid hematoma propagation. Avoid aggressive post-dilatation, which may propagate the hematoma proximally or distally beyond stent edges. And you'll end up having to further chase the hematoma. Also, you will see flap behind the stent. The reflex of some would be to keep post-dilating to further oppose the stent and collapse that hematoma. That's a wrong reflex. Avoid aggressive post-dilatation to avoid propagating the hematoma. So in our case, we had to stent proximally to stabilize the patient and before we do the distal work. This will make the distal bifurcation stenting more difficult, especially with GR4 guide, which is a poorly supportive guide. Inherently, I avoid a GR4 guide in transradial RCA PCI. And if used, you will typically need to use Guideliner for support. So we use Guideliner and we did distal nano crush perfect T. So we stented the PLB in an almost perfect T fashion. Then we crushed it with a balloon from the PDA. Then we stented the PDA. The issue here is that the 7 French Guideliner does not fit simultaneous stent and balloon for nano crush technique. In fact, it could not even fit 2.5 millimeter kissing balloon. So we had to do our nano crush sequentially, meaning I stented the PLB, then I advanced the balloon and I crushed it, then I advanced the stent and I further crushed it with a stent. I did not do the stent in the PLB while a balloon is stationed in the PDA. The 7 French Guideliner does not fit simultaneous stent balloon. It does not even fit simultaneous 2 kissing balloons. So 7 French Guideliner cannot fit simultaneous stent balloon for nano crush. It cannot even fit 2.5 millimeter kissing balloon. It may fit kissing 2 millimeter balloons, may tightly fit simultaneous stent balloon in an 8 French Guideliner as in a 6 French guide. Because 7 French Guideliner is like a 5.7 French guide. It's a little smaller than 6 French guide. 8 French Guideliner is like a 6 French guide. And this is the final result. Proximally and distally, we got a great result with a nano crush across the distal bifurcation. Now I want to point to one thing. This is how the stent looked proximally and the dissection behind the stent looked. We decided here to post-dilate because the stent was undersized. And this is what happened when we post-dilated. Compare the two. We post-dilated with a 4 millimeter balloon, and that hematoma behind the stent propagated more proximally. Luckily, it stayed within the stent edges, but this is to show you the hazard of post-dilatation. It may have been wise here to not post-dilate. And if you do post-dilate, be careful, avoid aggressive post-dilatation. This could have expanded into the coronary cusp. You may accept a slightly undersized stent. And it's very important to do IVUS in this case, which is what we did to prove that the stent has covered the dissection, especially the proximal entry point of the dissection. So you see the stent here, and we see that dark structure behind it, which is the subintimal hematoma. And I want to make sure that the stent is covering the dissection fully, especially that after we did the post-dilatation, it seems that the hematoma extended a bit more proximally. So we see here on the run, the stent, it's covering the hematoma, it's covering it all the way, including at the edge of the stent. You don't see any dissection proximal to the edge of the stent. And this is a reminder of the dissection classification that applies to all sorts of dissection, particularly stent and balloon angioplasty induced dissection. So dissection type A is just very mild haziness. Dissection type B, there is a line, parallel track, but no stain. Dissection type C, there is a stain in the wall of the vessel that persists after dye clearance. It's hard to differentiate dissection type C from perforation type 1, meaning localized perforation. In dissection type C, the dye stain is in the intima and media, whereas in type 1 perforation, that dye stain is in the adventitia. It's hard to differentiate. In perforation, that stain is deeper than in dissection, but again, it's hard to tell angiographically. So be wary of dissection type C, which is more benign than D through F, but it's concerning because it could imply a sealed perforation. Then you have dissection type D, which is the spiral dissection, often with impaired flow. So it's a dissection that's propagating distally in multiple planes, often with impaired distal flow. Then you have dissection type E, which is subtotally occlusive. And then you have dissection type F, which is totally occlusive. C through F are very serious dissection. A through B are more benign dissections that don't always need stenting. After coronary stand-alone balloon angioplasty, dissections A and B are benign over the long term and do not necessarily require stenting. Now, in the setting of stenting, if you see angiographically a dissection at the edge, it often requires a stenting, even if it is dissection A or B, except possibly if it is a dissection A or B that you can prove to be benign by IVUS, meaning it does not reach the media and is less than 1 quadrant. Now, if you have guide dissection, we generally stent regardless of that classification because guide dissection is always serious. This is another case of guide-induced dissection shared with me by my friend, Dr. Nestor Mercado at the University of New Mexico. So this is a patient he had who presented with subacute LAD stent thrombosis from an underexpanded stent in the LAD that was implanted 48 hours previously at an outside hospital. He used a femoral approach in this patient with a small body habitus and non-palpable radial pulses. The left main engagement was difficult, and it was eventually successful with a 6 French XB 3.5 guide, and he was able to successfully cross that stent occlusion with a work wire, and he did angioplasty with a 3 millimeter balloon of that underexpanded and undersized 2.5 millimeter DES. He got a very good result with just balloon angioplasty, and he proved with IVUS adequate stent expansion. Now, after IVUS, the guide catheter and the wire came out while pulling the IVUS system, and upon re-engagement with the same XB 3.5 guide, unfortunately, this is what happened. You can see guide-induced dissection of the left main extending into the LAD here on top, but also extending into the circumflex. You can see dye stain at that bend here, which is the circumflex. So we have dissection extending into the LAD on top and across that bend here into the circumflex. So what's the immediate next step? You don't have a wire here. So the immediate next step is to try to wire via that same guide, because guide engagement was very difficult in this patient. So try to wire via that same guide using the spinning maneuvers we described and avoiding buckling, typically with a workhorse wire, and that's what my friend did. He was able to wire very quickly and successfully without using much contrast at all. Again, he did not use contrast to avoid hydraulic extension of the dissection. He rewired it quickly using the wire spin helicopter technique with no issues. So after wiring, he stented from the ostium into the LAD, and again tucked the entry site, the proximal entry site of the dissection, and he stented into the LAD across the left circumflex, and this is the result. So excellent result across the left main and the LAD, but you see that there is still a dissection extending into the ostium of the circumflex into that OM1. You see that parallel track linear dissection into the OM1. Do not make the error of trying to wire that circumflex through the left main stent and double stenting. Do not make that error. You do not need to do that. Sealing the entry point of the dissection in the left main will eventually seal and collapse the hematoma in the left circumflex. In a matter of few weeks, that hematoma in the left circumflex will be fully collapsed and the circumflex will look a lot better, typically. So do not try to rewire the circumflex unless it has TIMI 0 or 1 flow. Always focus on tucking the entry point that will collapse the hematoma and reestablish flow, and the rest will typically heal on its own. And that's what my friend did, and he had a great result. Now I want to show you another case. This is a patient with severe LIMA to LAD anastomosis and LAD stenosis past the LIMA. Look again here. So severe LIMA to LAD anastomotic disease and severe LAD stenosis past the LIMA. Both are actually heavily calcified. Now, how do you treat those heavily calcified native LAD stenosis past the LIMA? You want to try to avoid using rotablation through a LIMA because LIMA is a flimsy and tortuous vessel, sometimes with a 360-degree loops, and you risk dissecting it with a rotablation advancement. I have had a great success in those cases using laser, and if needed nowadays, after doing laser, I follow it by shockwave lithotripsy balloon. So we use the left radial access, which is my preferred access in patient with bypass, and I use a 6 French IM guide. Unfortunately, we could not get the IM guide to be coaxial. Through that IM guide, we wire easily with a BMW wire. We could not even advance a threader 1.2 millimeter balloon through the anastomotic stenosis, further confirming my impression that this patient needs laser. So after we failed to advance the balloon, I did laser atherectomy. The arrow here points to it. I use a 0.9 millimeter laser, which successfully crossed both lesions and allowed us to advance a 2.5 millimeter balloon, which yielded very easily after laser. If that balloon did not yield, I would have used shockwave lithotripsy balloon, but that was not necessary here. Unfortunately, after stenting distally both the anastomosis and the LAD, we had guide dissection. And the reason for the guide dissection is that we could not get the guide to be coaxial, and we had to keep moving the guide in and out throughout our maneuvers when we are trying to advance the stent, which is not an easy advancement in this calcified disease. We had to push the guide in. So there were a lot of in and out movements of the guide, and that was one of the reasons for that dissection. So non-coaxial guide, a lot of in and out movements, plus contrast injection on a guide that's not coaxial. Even though we never were damped at any time, we still got a dissection, unfortunately. Now, this is what you see here. This image seems scary. There is extensive dye stain and dissection in the subclavian, not just the LIMA. There is dye stain in the proximal subclavian, the distal subclavian, and in the LIMA. as well as impaired flow in the LIMA distally. When the image gets very confusing, one may freak out, but keep calm and keep in mind how the dissection started. Where is its entry point? Just focus on tucking and stenting this entry point on the dissection, and that will seal the rest. Somebody here may decide to get femoral access and wire the subclavian and try to stent the subclavian. No, keep it simple. We have a wire across here. We know how the dissection happened. It started here and propagated retrogradely into the proximal subclavian, to the more distal subclavian, and antegradely into the LIMA. So all we did without any further contrast is bring a long stent, 3.5 by 38 millimeter stent. We covered the ostium, and we expected this to seal any further antegrade dissection, more distally in the LIMA, or dissections into the subclavian, proximally or distally. And indeed, that's what happened. After just one stent, we reestablished excellent flow into the LIMA, and you can see that we have no further dye extravasation into the subclavian, proximally or distally. Now we still have the previous dye stain into that hematoma. The hematoma is still there. It's just not expanding anymore, and it will be collapsing progressively with time. There is no longer any active dye spilling into that hematoma. This hematoma will heal gradually over time, over the subsequent few weeks. So keep it simple. Just take care of the entry site and the rest will heal on its own. And here also we assess whether there is a pressure gradient across that subclavian. We compare the pressure across the guide tip with the non-invasive cuff pressure into the right arm, and there was no difference between the two pressures. And this is the final image here. You can see very good result across the proximal LIMA as well as the LAD LIMA anastomosis and the distal LAD. And here again, excellent result across the LAD and the LIMA to LAD anastomosis with very good stent expansion. And this patient on follow-up few weeks later was doing great with no angina, no arm claudication, and no issues at all. I want to discuss a final idea that is extremely important that relates to guide dissection. What do you do when your guide dissection or any ostial dissection extends into the aortic cusp? This is what you call cusp dissection, or into the ascending aorta. This is treated via, again, ostial stenting. Ostial stenting will collapse the entry point and it will collapse the aortic hematoma. But I want you to understand this process here. Cusp dissection and aortic dissection that arises from ostial coronary dissection. The dissection in this case is different from a spontaneous aortic dissection. The dissection is a retrograde dissection. It starts from the coronary artery and it flows retrogradely opposite to the coronary flow into that aortic cusp. It may flow to the aortic cusp. It may flow retrogradely via the coronary entry point into the ascending aorta. But more commonly, it goes into the cusp. This is different from Stanford type A aortic dissection, which is an antegrade dissection starting from a flap in the aorta that gets amplified by antegrade aortic flow. So a retrograde coronary dissection in the aorta is more benign than the classic Stanford type A aortic dissection. And when that retrograde coronary dissection only involves the cusp, this cusp, what we call cusp dissection, or it also involves the ascending aorta, but less than 4 centimeters in height, not longer than 4 centimeters, Just stent the ostium and monitor the patient clinically and with a CT scan for a few days. Do a CT of the aorta same day and next day. However, if you have severe AI related to that cusp dissection may dislodge the hinge point of the sinotubular junction and cause severe AI, or that hematoma itself may impede the leaflet closure and cause AI. So if you have severe AI from cusp dissection, or if that ascending aortic dissection extends more than 4 centimeters, in those two instances, then you need surgery usually. And this is what we call the Dunning classification, which you need to know for your board. Dunning class 1 is aortic cusp dissection only. Dunning class 2 is ascending aortic dissection, but it's less than 4 centimeters. Dunning class 3 is ascending aortic dissection related to a coronary dissection that extends more than 4 centimeters. And that one requires surgical correction usually. So this is a case series from Israel. And in this registry, overwhelmingly, Dunning class 1 and 2 did not require any surgery, and they did very well. Whereas Dunning class 3, a little bit less than half of them required surgery, and 6.5% died. So the coronary dissection that extends retrogradely in the aorta more than 4 centimeters is serious and frequently requires surgery or leads to fatality. And this is a case from my book. A patient undergoes mid-RCA stenting. At the end of the procedure, it is noted that the ostium of the RCA has been dissected by the guiding catheter. The dissection extends into the right coronary cusp. What is the next step? Refer to cardiac surgery or stent the ostium of the RCA and treat the cusp conservatively with clinical and CT monitoring. The answer here is B. Retrograde cusp dissection is generally benign and heals spontaneously, as it is in this series. As long as the ostium is stented to seal the dissection entry site, it does not require aortic surgery. CT scan is performed and repeated to ensure the dissection does not antegrade extend to the ascending tubular aorta, in which case surgery may be needed. Surgery is particularly needed when the dissection extends more than 4 centimeters in the ascending aorta, or if the cusp dissection is causing severe AI.